They say 80% of your diagnosis come from the history, but the presenting illness is only half the story. What about the hidden clues in the patient past or the secrets tucked away in their family history? Today, we are finishing the puzzle. We are diving into the past, personal, and the family history before moving into the hands of magic of general physical and the systemic examination. If you want to stop just asking questions and start actually solving cases, let's get into it. So, let's start with past history. So, what is the purpose of past history? To connect current symptoms with the previous illnesses, identify the root cause or any related complications, to guide the accurate diagnosis, to identify the risk factors. Previous hospitalization is asked for any severity of previous health issues. Previous surgery is asked to check about any anatomical changes or any late complications. Now, what to ask in the past history? Ask patient about any similar complaints in the past, any history of hypertension, diabetes mellitus, tuberculosis, bronchial asthma, or any thyroid disorders, any previous hospitalizations, any previous surgery done, or history of blood transfusion. Now, next comes the family history. What is the purpose of taking family history? First, to identify the genetic predisposition. There are very common conditions like diabetes mellitus, hypertension, or ischemic heart disease that often runs in family due to the mix of shared genes and lifestyle. Second purpose is early screening and prophylaxis. For example, if a patient father has colorectal cancer at the age of 45, then the patient needs screening for the same. Now, what to ask in the family history? Ask patient about history of hypertension, diabetes mellitus, cardiovascular diseases, carcinomas, or any autoimmune conditions in their any of the family members. For example, in breast cancer patient, maternal family history is significant. Now the next comes the personal history. The purpose of personal history to identify the lifestyle related pathologies. First comes the diet. Ask if patient is vegetarian or having a mixed diet. If the person is on the vegetarian diet, then could have the high prevalence of vitamin B12 deficiency. Ask history about sleep. If the person has poor sleep, then it could be due to pain, any discomfort, paroxysmal nocturnal dyspnea, chronic stress, clinical depression, or obstructive sleep apnea. Ask about bowel history, that is, changes in consistency or frequency can be early warning signs of malignancy, for example, colorectal cancer, or inflammatory bowel disease, or GI associated conditions. Ask bladder history, for example, frequency, urgency, or any nocturia could be suggestive of UTI, which is common in females, and prostate enlargement, which is common in males. Now, let's talk about a major hurdle in personal history, that is addiction. Sometimes patient denies of consuming alcohol or about their smoking history. When you feel like you aren't getting full history, ask to their family members. Now, what are the addictions? There are different forms of tobacco consumption, like cigarettes, BDs, cigars, pipe, e-cigarettes, smokeless tobacco, etc. Take the history of number of cigarettes smoked per day along with the duration to calculate the pack years. Pack years is equals to number of cigarettes smoked per day into the number of years smoked divided by 20. One pack is equals to 20 cigarettes. For example, if a patient smoked 10 cigarettes a day for 20 years, then they have a 10 pack year history.
So, what to ask in addiction history?
Age of onset, duration, that is total years of active smoking, current status, that is he is an active smoker, an ex-smoker, or never a smoker. For ex-smokers, you should ask about when did they quit and calculate the smoking index. Next is the alcohol history. What you need to ask is about type of alcohol, quantity, ask about the amount of intake, ask about the frequency, is he a daily consumer, drinks on weekends or occasional drinker. Ask for the duration, that for how many years he has been drinking, and calculate the units of alcohol. Next comes the summary. How to structure your summary. First, tell in brief about patient's profile like age, gender, occupation, known comorbidities. Second is the chief complaint and its duration. Key positives, that is, only the symptoms that support your primary diagnosis. Key negative, only the pertinent negatives that rule out your big killers. That is, for example, there is no history of chest pain, fever, or leg swelling. Social or personal history, if relevant. That is, for example, history of smoking is very significant in COPD patient. So let's see an example how to structure your summary Mr. X is a 60-year-old smoker and a known hypertensive who presents with acute onset central crushing chest pain radiating to the left arm for 2 hours, associated with diaphoresis. He has no history of trauma or any similar episodes in the past. This present is highly suggestive of acute coronary syndrome. Now, next come how to write the differential diagnosis or how to approach the differential diagnosis. So, there are 4 points to be remembered. The rule of 3. Always try to have at least 3 differentials. Second point, most likely what fits the majority of the key positive is the working diagnosis, the must not miss. Even if it's unlikely, you must include life threatening conditions or any comorbidities. Fourth one is the anatomical versus systemic approach. If you are stuck, think about the organs in that area. Now, next comes the general physical examination, divided into 3 parts. First part is of vitals, second part is of pickle, that is pylorictus cyanosis, clubbing, lymphadenopathy, and third part will be the head and toe examination. So, what you will see in the general physical examination, first start with the condition of the patient, that is, if he is conscious or unconscious, cooperative or not, does know about the whereabouts or not. For example, patient is conscious, cooperative, and well oriented to time, place, and person. Then next comment about the lie of the patient. That is, patient is in sitting position, supine position or decubitus position, etc. Then comment about the nutrition of the patient. That is, patient is thin, average or obese. Now take the height, weight and calculate the BMI of the patient. First part of general physical examination is the vitals. First point is pulse. Describe it into 7 points. Rate, rhythm, volume, character, vessel wall thickening or the condition of vessel, radio-radial or any radiofemoral delay, peripheral pulses. On examination, the radial pulse is 70 beats per minute, regular in rhythm with normal volume and character. The vessel wall is not palpable. There is no radio-radial or radiofemoral delay, and all peripheral pulses are felt equally on both sides. After pulse, the next vital is the temperature. We have to describe it in degree Fahrenheit or degree Celsius along with the grading of fever. That is, for example, patient is febrile with a recorded temperature of 102 degree Fahrenheit measured axillary. Now, next vital is the respiratory rate. It is dash per minute, abdominothoracic for males and thoracoabdominal for females. If patient have any respiratory distress, then comment on the use of accessory muscles of respiration. Next vital is the BP. It is recorded as dash mm of Hg. Mention taking in which position and also mention about which arm it is taken. For example, 120 by 80 mm Hg measured in right arm in sitting position. Next vital is the jugular venous pressure and then pulse oximetry. In the second part, we describe about pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. And in the third part is the general head-to-toe examination. For that, we have to check eyes, skin, nails, oral cavity, mucous membrane, etc. Now, the last part is the systemic examination. What is the purpose of taking systemic examination? The primary goal is to localize the pathology, confirming or refuting the differential diagnosis, detecting any asymptomatic finding of any chronic conditions. What are the prerequisites? Before taking in systemic examination, mention about well lighting and adequate exposure for examination. Take consent of the patient before examination and always prefer to stand in the right side of the patient. For abdominal, respiratory, and cardiovascular system, examination is done in the following headings: inspection, palpation, percussion, and auscultation. For the central nervous examination, it is divided into 7 parts: higher mental functions or consciousness, cranial nerve examination, motor nerve examination, sensory system examination, reflexes, cerebellar signs, gait, etc. Now that we have covered the basics, our next concern is vitals, starting with the temperature. In the next video, we'll be covering everything from the physiology behind it to the clinical significance of your findings. I'll also be sharing some Viva pointers that I have gathered from my own posting. Don't forget to subscribe so that you have a quick reference for your final year practicals.